let's get started. Welcome back to our second annual Prepare NSF Rapid PI meeting. For those who haven't joined yesterday, Prepare is an NSF-sponsored virtual organization intended on building a community of multidisciplinary researchers to take on the next pandemic. And like Wendy Nielsen yesterday said, that the goal is to work interdisciplinary, break those silos. And yesterday was fantastic, and today promises to be just as enlightening. And we will start with our keynote speaker today, and it's my pleasure to introduce Amira Roess. She's a professor of Global Health and Epidemiology at George Mason University's College of Health and Human Services. Her expertise is in infectious disease epidemiology. She leads several longitudinal studies, including on the emergence and transmission of MERS-CoV with support from the NSF, and the development of COVID-19 in the first year of life with support from the NIH. She's also working on a number of other COVID-19 projects, including examining infection disparities and use of mHealth, especially apps, to enhance surveillance and contact tracing. Amira holds a PhD in global disease epidemiology and control from Johns Hopkins University. And prior to joining academia, Dr. Roess served as an Epidemic Intelligence Service Officer at the CDC. And I think Amira is a great choice as a keynote speaker for Prepare, as she fosters collaborations with computer and information science. For example, this year, Amira also gave a keynote at the SSTD conference, the Symposium for Spatial and Temporal Data, and a workshop at the ACM Spatial Conference on Spatial Computing. And yes, without further ado, Amira, the stage is yours.
Thank you, Andreas, for that very kind introduction. Okay, so today I'm going to talk a bit about the practicalities of multiple disciplinary research and really focus on lessons from COVID-19. I'll present a brief overview of what our team is doing, who's involved. We'll talk about pandemics throughout history and the global infrastructure that's been set up to respond to pandemics, with some more in-depth discussion about the COVID-19 pandemic and what's worked and what hasn't worked. And then we'll go into what multiple disciplinary research is and the implications for research training and public health practice. And then we'll end it with a discussion about ways forward, where the research gaps are and where the practice gaps are. I really do need to acknowledge the large team that I've been very fortunate to work with from all over the world and a number of different universities and organizations here in the US as well, across many disciplines. We've been very fortunate to get funding from NSF, NIH, the Bill and Gates Melinda Foundation, and other foundations as well. So most of the work that our team does is really focused on infectious diseases, especially emerging zoonotic disease epidemiology. And all of that work has a very strong social behavioral component where we're trying to really understand human behavior and other factors that impact both the emergence and the transmission of these emerging diseases. And for a couple of these projects, we're also looking at the links between humans and the environment. For example, we have one study that's looking at the exposure to what we call forever chemicals. These are in pots and pans and deodorants and a lot of different things. We know that they're immune modulators. So we're looking at that as well. And as much as we can, we also think about the policy or the structural implications of our work. And we've worked on a number of different fronts in that regards. Some of our work also tries to utilize technology to both improve our research and to pave the way forward for innovations in public health practice. So pandemics throughout history, basically, for as long as there have been people, there have been pandemics. And we know that pandemics have really shaped history. You could see here the mention of plague multiple times in the 1300s, there was the Great Plague, which affected Europe and led to about 40% of Europe's population dying over the span of 4 years. The Great Plague and many other pandemics, of course, are tied to global movement and global economies, right? And that really hasn't changed as being an important driver. So here we have the Great Plague, which had a case fatality rate of 80%. And this means that out of everyone infected, 80% would die. Of course, now we have a very effective therapeutic, and we don't really see high mortality once plague is identified. Some of you sure are familiar with cholera that had a 50% mortality rate. And again, we have now treatments and therapeutics that have drastically cut down the case fatality rate. When we talk about SARS-CoV-2, the current pandemic, oftentimes there are parallels that are drawn to the Spanish flu or the Great Influenza, the 1918 flu. And the 1918 flu had a case fatality rate of about 2.5%. That means that 2.5% of those who were infected died, and that is a large number. In comparison, SARS-CoV-2, before the introduction of the vaccine, here we saw that the case fatality rate was 3.4%. So it is higher than the 1918 flu. So a couple of things happened since the 1918 flu. There was the modern discovery of antibiotics in 1928. And then in the 1940s, we saw the introduction of mechanical ventilators, as well as upscaling of flu vaccine development. Vaccination has been used very successfully to control many infectious diseases, most notably smallpox. We've been able to eradicate smallpox. And there have been lots of attempts to develop vaccines for coronaviruses. Now, since 2002, we've seen the emergence of 3 major coronaviruses that led to either large epidemics or pandemics. So in 2002, there was the first SARS that emerged primarily in East Asia. And some of us remember Canada was affected with a number of outbreaks. The case fatality rate for the first SARS was about 10% when all was said and done. Early on in the pandemic, the case fatality rate was estimated at about 30%, but as more cases were found, it went down. However, 10% of individuals who were found to be infected died, and that is a very large number. Then in 2012, MERS coronavirus emerged with a case fatality rate above 30%. And we are still seeing MERS cases, especially in parts of the Middle East and around the Arabian Peninsula. And then, of course, 2019, we saw the emergence of SARS-CoV-2. So where do emerging and re-emerging diseases pop up? Well, basically anywhere in the world. Here you can see some of the coronaviruses highlighted on this map: MERS, SARS-CoV-2, the first SARS, and there are a number of other infectious diseases that we have highlighted here, from Ebola to Nipah virus, dengue, and West Nile, which are all linked to mosquitoes. So what we taught in our classes pre-COVID-19 was that the 1918 pandemic was something that would never happen again, because we would tell our students, we know better. We have great systems in place that help us to communicate about emerging infectious diseases. When I was a graduate student, my professors at Hopkins would often say that infectious diseases are over. You all need to really focus on non-communicable diseases, heart disease and cancer. These are the things that are going to be creating opportunities for employment. And with this idea, we also built a system to try to address these infectious diseases, but always with the thought that we have antibiotics, we have vaccines, we have other ways of dealing with emerging infectious disease threats. And in 2018, we remembered the 100-year anniversary of the emergence of the H1N1 virus. And we mark this by really patting ourselves on the back and saying 100 years later, we have such a great infrastructure, a global infrastructure built to really address emerging infectious diseases. And one thing that everyone was very proud of was the fact that we have these international health regulations that are run by the World Health Organization. These regulations evolved over time from the days of the international sanitary regulations that tended to really focus on specific infectious diseases like cholera. And what you could see here is prior to the current iteration of the international health regulations, the way that we looked at infectious diseases and pandemics was really at a disease-specific level. So we talked about cholera, plague, yellow fever, and smallpox. And as we moved forward in time, we realized that we really need to update how we talk about public health emergencies to be more inclusive and broader, and to include things like accidental emergence of infectious diseases or toxins and things like that. The way that we communicated about emerging infectious diseases started to change from countries primarily faxing reports to the World Health Organization to having a national focal point in every country, and it's 196 countries that are part of this agreement. 196 countries work together to report public health emergencies to the WHO. So a number of things evolved over time, and a lot of global health practitioners really felt as though we were making good progress in responding to these infectious diseases. And one of the main changes here was that prior to the current iteration of the IHRs, the World Health Organization could not initiate an inquiry. That meant that they could not go to a country and say, hey, we heard rumors or we've received information from an unofficial source that you have an outbreak of measles, you have a possible case of monkeypox, right? They really relied on the country officially reporting to the WHO, whereas now the WHO can actually go to the country and initiate this request for information based on rumors or news reports or other sources of information. And this has made a big difference in how we have moved forward in our response to infectious diseases. But it really does rely heavily on this global cooperation and having a strong World Health Organization that has active membership. And this is to give you a sense of how complex it is to detect a public health emergency and then to report it up to the national level, which then reports it to the WHO. So you can see here that there's a lot that happens at local levels, and you can think of this as a city or a town or a village, and then up through the district level or a county or state level, or a governorate, depending on what country you're in. And here we have a number of different questions that have to be answered at all of these levels before a determination is made as to whether or not this event is something that could be classified as a public health emergency. And then a decision is made as to whether or not to report it to the WHO. But as I mentioned, the WHO also now has the ability to go to a country and say, we heard from the local newspaper that something might be going on, and an inquiry is set up that way. And I wanted just to share with you that the IHRs have really done some good in increasing the number of reports. This is just from our hemisphere here in the Americas. And you could see over time the number of events that were being entered into the IHR system. The colors are the continent. So South America is green. And then you have other parts of the Americas region here reporting a number of different events. One thing that we keep asking ourselves is what happened that led to our systems maybe not working as efficiently as we had hoped they would work? What led to such a large pandemic? So the first thing is that there was some delay in the recognition of a novel pathogen and in the reporting to the global community. But I think we should also remember that in 2002, when the first SARS emerged, it was a very different timeline for when the global community was notified. So 2002 was before the IHRs gave the WHO the ability to go to a country and bring up the fact that they heard a rumor, right? So what happened in 2002 was that there were some cases that were noted by clinicians in China of severe pneumonia and other respiratory distress. And the WHO started to hear rumors after a few weeks, and they sent over a team to go to the hospitals where they were notified that there were cases. And some of you may not remember this, but what ended up happening was that the cases, the patients were put into ambulances. And while the team, the WHO team, was inspecting the hospital and conducting interviews, the patients were being driven around the city in order to avoid detection. So a lot has really changed in less than 10 years, in that China was working pretty closely with the global community in terms of reporting SARS-CoV-2. And again, remember, it's been less than 10 years, and the approach and the communication has improved. It may not be as robust as we would like it to be, but we should remember the historical context and what happened with the first SARS. So with COVID-19, one thing that a lot of us in the US have been talking about has been really this failure to implement protocols that we had in place for just this thing. I worked at the CDC as an outbreak investigator, and there were drills and exercises and lots of events that really had us practice what we would do in the event of a public health emergency. In 2009, H1N1 emerged, and there was a lot of implementation of these various protocols, open communication with various countries to try to understand whether or not this was going to be a large pandemic and how large could we expect and so forth. And so a lot of us expected that those same types of protocols would be implemented in the face of SARS-CoV-2. And unfortunately, that didn't happen. And a lot of us who were at the CDC, outside of the CDC, at state and local health departments who talked about this, did sort of, wring our hands as to, well, why aren't these protocols being implemented? Why aren't we seeing an improvement from the 2019 pandemic response? And so I think there is a lot of work that needs to be done in this area to figure out where the weaknesses were in our preparedness plans. Was it simply a matter of political will, or was there something more that needed to be addressed? And when I say simply political will, right, it's never simple. The other thing that we saw was that there was slow movement to enact quarantine. Some people believe that an effective global quarantine should have been put in place early, while others are looking at this from the lens of a global economy and saying this isn't practical anymore. We can't just shut down commerce. We need other mechanisms. But right, we all know it's a virus. It doesn't care. It moves around. And so we need to, I think, rethink this. Right now, in the face of the Omicron variant, there is talk about limiting movement from parts of Southern Africa. And whether or not that's going to be effective, it's a matter of debate. And there's a lot of strong feelings on both the pros and the con side. With COVID-19, right, we were all expecting to see variants emerge over time. And when the Delta variant emerged and was significantly more transmissible than the previous variants, there was a lot of concern about what to do and a lot of discussion about why we weren't able to detect the variant earlier. And here in the US, we have been discussing for years about our lack of genomic surveillance and our general limited public health surveillance. And so the failure of having a robust genomic surveillance system in the US does put us at a disadvantage in both tracking emerging variants and also coming up with more efficient ways of really addressing transmission and spread. The other thing that we're seeing is in the face of a highly effective vaccine and highly effective against severe illness, hospitalization, and death, We're seeing this rise in vaccine hesitancy that doesn't really coincide with the highly effective nature and the safety profile of this vaccine. And so there were some real missteps in both communication and in planning for vaccine hesitancy. People who work in the space of vaccine hesitancy have known for over 20 years that this was going to be a continuing issue for public health. It was going to continue to really chip away at our public health infrastructure. And this was something that I think we really should have been prepared for. Another big thing that we talk a lot about now, and we heard talks about this yesterday, is the cultural and political resistance globally against vaccines and masks, social distancing, and movement restrictions. And there was also this surge in nationalism in general, globally, and also vaccine nationalism that has really hampered our response. A big question, right? With all of that background, a question that we're all asking ourselves is, how did we get here? Why didn't we have a strong or robust public health system or surveillance system? Well, so there are a couple of things that those of us who work in public health grapple with. First, when public health works, that means when you don't have large numbers of infectious disease deaths, when you don't have high infant mortality or high maternal mortality, when your water supply is safe, what tends to happen is that funding and support for public health systems goes away. And we start chipping away bit by bit at this system that has made us all safe. And it's very difficult to come back from that. And I like to share an example. When I was at the CDC in 2008, this was the time of the Great Recession, as it's now called. And the consequence of that recession on the public health system was that it really caused a large number of individuals to leave public health departments, local and state health departments, because the idea at the state and local level was, we're going to deal with this recession by furloughing our state and local workers, including our public health workers. And so a lot of my colleagues were told 1 day a week, usually on Fridays, you do not come to the office and you will not be paid that 1 day a week. And so what ended up happening was that a lot of individuals, they moved on to other jobs, right? They needed to support their families. They needed some stability. And that was sort of another nail in the coffin for the public health system that was already suffering. You can see here as an example from 1965 to about 2015, this is a recent article, the federal government's contribution to public health systems has decreased significantly over time, right? And here's what happened in 2008, and right after in 2009, we had H1N1, that pandemic, and there was an influx of funding to try to handle the 2009 pandemic. Another thing that's been going on, not just with coronavirus research, but with lots of other aspects of research, is the funding that we contribute has gone down over time as well. So here you can see from 1921 to 2020, and some of you may recognize this, it was in the New York Times earlier today. You can see that nearly 2% of our GDP was spent on research and development, and that has gone down significantly over time. How we compare with other countries, other high-income countries, we're really nowhere near where we once were, as you saw in that previous graph. And people argue we really should be rethinking this. The US's strategy for decades was that we would support research and development, and in turn, there would be a sweet spot where industry would then take over and move on and generate revenue that would go back into the country's tax base, for example. And so the rationale was there, the evidence was there that this was a good strategy. And ironically, China and other countries adopted our strategy just as we were moving away from it. So there are a few things about how we handle public health emergencies from a funding perspective that have, I think, and others have argued, that has a direct implication on our preparedness and our long-term research base. So what you see here is that whenever there is a pandemic or a public health emergency, you see an influx of funding, supplemental funds contributed from the federal government. So what does that mean in practice, though? Well, often a lot of my colleagues and I, some at DoD and elsewhere, we talk about how people have to be nimble, scientists and researchers have to be nimble, and they have to be able to go after these funds in order to keep their research portfolio growing and going. Well, what tends to happen with this kind of reaction is that after the emergency passes, the funding dips immediately, and then everyone sort of scrambles to go back to whatever it was that they were working on previously, or to move on to something completely new. Now, this is a very different approach compared to what others have. Let me just also share a story here. So when MERS coronavirus emerged in 2012, I was working in the Middle East at the time on a couple of other zoonotic disease projects. And my colleagues and I were really interested in working on MERS coronavirus. And we started to do some small projects together. We wrote a couple of short pieces together, and we were building our team and looking for coronavirus experts, coronavirus researchers. I looked in the US, and my other colleagues in the US were also looking to see, where are the coronavirus experts, the virologists who could work with us on these field projects. And what we found was that the real coronavirus experts were in East Asia and were also in parts of Western Europe. So we started to work with a team in Germany. Their approach to research funding and to building up their research programs is very different than what we were doing. So when SARS first emerged in 2002, we had funding that went towards, it's not on this graph, but we had some funding that was allocated to coronavirus research, to SARS. And in the US, it went away very quickly. There was a little bit that stayed, but nowhere near what our colleagues in Western Europe and East Asia saw. So the folks in Germany, in the Netherlands, in countries in East Asia, they continued to work on the first SARS and on other coronaviruses, and they had sustained funding to keep them engaged in coronavirus research, and they continued to work on it. And so in 2012, when MERS emerged, it made sense that they had the infrastructure ready to go to work on that coronavirus. And so we partnered up with the team in Germany, and to a lesser extent to a team in Hong Kong, and built up our field site and our research program. And it was really challenging for us to get US funding for MERS coronavirus work, but we were able to, and we continued to work on this. And then when SARS-CoV-2 emerged, it's all of our colleagues throughout the US who were working on emerging zoonotic diseases were expecting that we would see this, exactly what we're seeing, right? A real boost to funding for SARS-CoV-2. And now we're trying to figure out, what does this mean long-term? I also share that it's not a coincidence that a lot of the innovations and the developments in therapeutics and vaccines have really been built off of the work that has been done in the coronavirus labs abroad and overseas, right? And that also, I think, gives us a very good justification for building our global partnerships and our global health partnerships and programs. No one country could do the work alone, and nor should they, right? We rely on scientists throughout the world to produce work that we could build off of. The US wasn't doing robust coronavirus work, and from an economic or political standpoint, maybe there was no justification. We weren't near the hotspots where these viruses seemingly emerged, right? That could have been the argument for why we didn't have such a robust coronavirus program as other countries did. Well, having that partnership with folks in the Netherlands and Germany and Hong Kong, in Japan, helps us to stay engaged in that field. And I think a lot of us have to continue to move forward in our global partnerships because there is a lot at stake. over the last year and a half, especially in 2020, there was a lot of rhetoric over the US disengaging or leaving the WHO. And there was, as you could see here, a real decrease in the US's commitment to global health, at least from a policy level. That is dangerous for global health security because the international health regulations, the global health security agenda rely on it. A lot of our research partnerships benefit greatly from having robust partnerships with scientists throughout the world. So another thing that has been happening decades in the making has been, our siloed approach to just about everything to do with research and public health. In the public and the private sectors, and universities and in funding, it has been traditionally challenging to get funding across colleges or schools or disciplines. And that has been changing over time. And I think the SARS-CoV-2 pandemic has accelerated opportunities for breaking down silos, and more of that is needed. We see oftentimes there's a real difficulty to have individuals work together, for example, on integrating animal disease surveillance and human disease surveillance, right? That's something that a lot of us working on zoonotic diseases have been saying really needs to happen, but it's very difficult to do this, especially when the funding for these activities comes from two different places, CDC, human, USDA, animal, for example. And there are growing programs to try to co-fund and allow for collaboration to improve the communication between the human and the animal surveillance systems. So a lot more of that is needed. And because we don't have a tradition or a culture of that, I think it does make it difficult to have the systems in place to allow us to effectively bring the data together and find out where are there spikes in animal disease issues that may have impacts on the human health side. Another consequence of these silos has to do with the difficulty a lot of us have had doing multiple disciplinary research, or at least supporting multiple disciplinary research. When I was a graduate student in the School of Public Health, I was really interested in looking at the interface between humans and animals. And a big question that I had is, how does the behavior of one impact the behavior and the health of the other, especially looking at antibiotic use and resistance. And so, I approached a lot of the public health leaders and professors and said that I really want to work on the use of antibiotics for livestock and small animals in remote areas and in rural areas of South Asia, and to see what that meant for antibiotic resistance of human pathogens or pathogens that have significant human clinical importance. And the reaction that I often got was, why? What do animals have to do with anything? First of all, no one is using antibiotics for their animals. And secondly, even if they did, that has no bearing on human health, right? And so that was about 20 years ago, and a lot has changed since then. Most people who work in public health are acknowledging what animals do and how humans and animals interact, right? It matters a lot. We see that now very clearly. And as I mentioned, there was this thought that infectious diseases are over. People really need to focus in on the non-communicable diseases. With an infectious disease, we have antibiotics, we have vaccines. We're done. We don't need anything else. So let's talk a little bit about what multiple disciplinary research is. First, a lot of us are trained in an intradisciplinary space, meaning we're working within a single discipline. We're getting our training, in-depth training within a single discipline. That is very important. As someone had mentioned to me, listen, if you aren't very good technically at something, then how can you possibly contribute to a multi or an interdisciplinary effort? And there is a lot of truth to that. And we don't want to forget that piece, right? We do need our students to be very good technically and to be engrossed in their specific discipline. The other part of this is the multidisciplinary research field. And this is when we're bringing researchers together from different disciplines to work together, but they're not necessarily integrating the methods or the theories from their separate disciplines into something more robust. Multidisciplinary work is a great first step in bringing disciplines together, and it is really needed to build up our more complex interdisciplinary teams. And I think here in the multidisciplinary space, we are starting to see some more training happening, at least to graduate students. Then there's the interdisciplinary research, which is integrating the different theories and methods of various disciplines. And here we're trying to come up with new approaches to tackle some of our pressing public health or other research questions. And then finally, there's transdisciplinary research or transdisciplinary practice. And this unites all of these various frameworks and methods and is often coming at a large problem and is much more practice focused. It's taking the research that has been generated in the interdisciplinary space and then trying to apply it towards a greater good. Now, one thing that I found myself often sharing with people is that, multiple disciplinary research is not for everyone, and that is okay, right? The worst thing we find often is that people are trying to force themselves to do the interdisciplinary or the multidisciplinary work, and they're not convinced that this is what they need to do, but it's all the rage, right? This is the lingo, and there's this feeling that they need to do it or they're going to get left behind. There's still plenty that needs to be done that can be done well in the intra and multidisciplinary space. There are a few things that we need to teach our students when we start to teach about multi and interdisciplinary research. And a lot of this really has to do with what are called soft skills. Sometimes I share some stories of building teams together to do interdisciplinary work and finding that sometimes the researcher just feels like, he's not a good fit. And he tries to work on this interdisciplinary team, but then he just kind of bows out, and that's fine, right? We bring in someone else who is really interested in interdisciplinary work and is able to do that. So our graduate students, I think, would really benefit from training in these soft skills that maybe some of us didn't have opportunities to get. And these include, first, they need to do the in-depth training in their field, that intradisciplinary approach. Then they also need exposure to the different multiple disciplinary research approaches. They also need training in how to work on multiple disciplinary teams. And working on interdisciplinary teams, for example, it really requires that individuals have a certain level of humility and respect, and that there is no thinking that, my discipline is the way to go. This is where hard data comes from, right? I've been in situations where you had a statistician sort of make comments that without their contribution, the rest of the project is really not going to go anywhere. And only hard numbers are what we need to move the field forward. And that is really destructive for building an interdisciplinary team and for the morale of the team, right? If you find that happens, what you end up seeing also is that the trust between the team members starts to go away. It starts to break down. A really important part of doing interdisciplinary work is having a team that truly trusts each other and truly respects each other. And, we're human, right? We are always looking for a tribe that we could attach ourselves to. And sometimes that means that, I want to stick to epidemiologists. I want to stick to spatial scientists or what have you. We have to train our students to be aware of some of these inherent biases, and we ourselves have to be aware of these biases so that we can remove them from our discussion when we teach both intra and interdisciplinary research methods. Another really important soft skill to have that some people are able to do it, some aren't, it's openness, right? And a real ability to listen to other perspectives, to acknowledge that other disciplines have a lot to offer. And this is key to helping the teams learn from each other and truly move the science forward. Here, I wanted to share just a schematic of one of our ongoing MERS coronavirus research studies that's funded by the NSF. So here we're taking an interdisciplinary approach here, and we have what we call the social sciences, the epi or the health sciences, and the environmental climate sciences. And we are using methods from each other's disciplines and modifying them, and also trying to rethink the discipline-specific theories. We're trying to rethink them in a way that incorporates theories from our colleagues' disciplines. This has been a really fantastic project to work on, and challenging at times, because every instrument that we developed, we needed buy-in from all of the other team members, and we also needed to understand how the data would be viewed from their discipline's perspective, and how we could modify the data collection so that we can come up with new sources of data, new types of data that could then come together into a new type of model that would help us better understand what the predictors of disease spillover could be. Here, I just wanted to also highlight the complexity of some of our projects. The MERS coronavirus project is one of them, where we have individuals from multiple disciplines, from multiple countries coming together. We have not just our disciplinary biases to deal with, but then also some of our cultural biases that come into play. And again, this kind of work is not for everyone, and that's fine. But when you are able to do it, it's very gratifying. Research practice gaps and role for interdisciplinary collaboration. There are many gaps that have been highlighted from the pandemic. First, there's the large research gaps that we're seeing in genomic capabilities, especially here in the US when we're thinking of surveillance. The human behavior side, there is a lot that we need to focus on, and I'll talk about these in some detail. So first, the US is trying to catch up with a lot of our counterparts, a lot of our high-income counterparts. I mentioned that our public health surveillance system was slowly chipped away out for decades. And lots of countries in Western Europe have built a phenomenal genomic surveillance system, and we've been far behind for a very long time. And that has been something that public health and other experts have been talking about for years, if not decades. This is our opportunity to really catch up, but to try to leave something that's more robust and permanent instead of this way of fad funding, right? There has been a lot of talk about using genomic capabilities as an early warning system, and a lot of funding in the US had initially gone to this. Some of you might be interested in reading this commentary in Nature that was published in 2018 that talked specifically about the Global Virome Project. One idea was, well, we should catalog all of the viruses in the world, and by doing so, we will identify which ones have pandemic potential. And what ended up happening was we cataloged thousands and thousands of viruses and really weren't able to correctly identify which ones might have pandemic potential. So a lot of work is really needed, basic science work, and maybe more focused funding is needed to better explore this area. Genomic and phylogenetic analysis can really help us identify the source of outbreaks, and this is important for disease control, as we all know. Here is just one example from a couple of papers out of the UK, where they just sort of visualize SARS-CoV-2. The colors here coincide with where they are geographically. And you could sort of see, if you can look at this in some detail, the movement of the variants around the world. So a lot of work needs to be done on this in the US especially. In HIV, there's really good case studies that show that you could use genomics to better prioritize control, meaning there are some strains that we know are transmitted more easily by injection drug use, for example. And so one idea is that if you could identify a patient who has a large number of that strain of HIV, you could prioritize making sure they have clean needles and that they don't share needles, as well as making sure that they have enough treatment so that you could reduce the probability of transmission of that strain to others through IDU or injection drug use. So there's been some very interesting work in that space that could help us understand how phylogenetic data can be used to help with control. And of course, if you have treatments, you can look for resistance and better tailored treatments. And with SARS-CoV-2, there's a lot of work that we're doing now to try to understand how to improve vaccines and therapeutics to make them more effective and more responsive to emerging variants. I will then just wrap up by mentioning a few other things that we knew were going to become a problem with SARS-CoV-2 did become a problem, and we are really behind in coming up with innovative ways to address things like vaccine hesitancy, improving behaviors so that people wear masks, for example, contact tracing apps, great innovation, used well in some countries, but in the US, this just really didn't work and was probably a failure of interdisciplinary collaboration and really having the folks that are on the ground contributing to the development of these apps and the rollout of these apps and implementation of such systems. Early on in the pandemic, in April of 2020, those of us in public health who were working on disparities did see the writing on the walls that COVID-19 was going to become a condition of the have-nots. We have a history of systemic racism and health disparities and other disparities in the US. And this was something that many people had been warning about and advocating for funding to address this. Because of our history and our gross gaps in life expectancy by race, ethnicity, and other health outcomes, it was very clear that we would see disparities in COVID-19. But it took months, and we're still behind in trying to get funding and appropriate interventions in place to address these disparities. For those of us who are in academia, you might be interested in looking at this. The academies came up with this report just earlier this year. And the bottom line is that we need to do better to address structural racism consequences, including in academia. Our curriculum can have meaningful additions to include populations of color. How we address healthcare access, I think those of us who work in academia could do a better job of training the next generation so that they're aware and able to address this. There's also a lot of work that needs to be done to address this issue of how do we keep health departments funded, especially those that are working with low resource settings. Thank you.
Thank you, Amira. I just want to make one little comment. And Amira, I really like your slides on collaboration and that collaboration is hard and not for everyone. I remember in August 2020, there was a workshop at the ACM KDD called Deep Spatial, Deep Learning for Spatial Data, and it had a panel which featured 3 NSF program directors, including Amarda Shihu, Wei Ding, and Wei Xin Ku, and also Shashi Shekhar from Minneapolis. And one of the questions that was asked was, why doesn't deep learning work for COVID? Why can't deep learning and machine learning methods, why can't they solve COVID? Why can't they tell us who will become sick when and whom to isolate up early? One of the answers was that there's just not enough data because the word unprecedented was very common back then. But one of the other conclusions was that we need to work interdisciplinary and we need to include epidemiologists and social scientists in our models to have the domain knowledge. And I think that's what this workshop is about, to connect these different disciplines. And we have rapid PIs from SCIENCE, from SBE, and from Bio. And I hope that maybe some of you are able to find these connections where we can work together interdisciplinary. So thank you again, Amira, also for talking about the challenges in working interdisciplinary.